right, so let's get into the meat of it. I just had a pretty short question. So I'm going to talk about a lot of agents that have been in clinical trials over the last 5 years. I've been very involved with the development of many of these. I've worked with many companies. As Corey in the front here would say, I'm conflict of interest promiscuous. But it has been important. It has been important because when we started this, even 6 years ago, there was nothing. And so we really had to work hard to get the pharmaceutical industry interested in what we're doing. So thyroid cancer, for a brief refresher for anybody who hasn't seen it in the last few years, we have two different cells of origin. We have either the parafollicular C cells, which give rise to medullary thyroid cancer, or we have the follicular cells that usually make thyroid hormone, and they give rise to either differentiated, of which we have 3 subtypes, papillary, follicular, and Hürthle cell, or we have anaplastic, which is a very nasty disease, and one which I will not discuss today. So if you look at thyroid cancer in the United States over the last 5 years or so, it turns out that we are having an increasing number of patients who are diagnosed. And while some of this is definitely due to increased detection due to other scans and things like that, there is some data that there actually is an increased incidence. And if you look in the SEER databases, it's clear that it's going up, and it's probably not just detection, and it's not clear why that would be at this point. So the first part of my, 2/3 of my talk will focus on differentiated thyroid cancer. And patients who are treated or have surgery like any other head and neck cancer, and hopefully a definitive surgery is completed. After they've had their thyroid out, interestingly, all patients, virtually all patients, will be treated with radioactive iodine. And how much they get depends a little bit on whether they're high risk or not high risk. Most of it initially is given to get rid of any residual thyroid tissue so that then you can use iodine uptake to actually detect recurrences later. However, if people had positive margins and there's a concern that they are high risk, sometimes they will also be given a higher dose, which is more like a treatment dose, usually over 100 millicuries. Following that, patients are treated with TSH suppression. So thyroid hormone, and understand that all of this happens before they come to the medical oncologist in most cases. The thyroid hormone suppression is really that they're given replacement thyroid hormone. Obviously, they need thyroid hormone once their thyroid's out. But what happens is that the levels are kept a little bit high so that the TSH is actually kept suppressed. And the reason for that is that TSH is a growth hormone for thyroid cancer. So like any other growth hormone, we'd like to keep it low. Then these patients are followed with serial thyroglobulin, ultrasound to the neck, sometimes neck MRIs, depending on their risk. And then eventually, if they have recurrences, occasionally they will be given multiple rounds of radioactive iodine, especially if it looks like on another scan that the recurrences are what we could call RAI avid or well, yeah, it's just RAI avid, that they're taking up the radioactive iodine. And we can also follow these patients more and more with PET, and I'll talk a little bit about that as well. So the problem is that when you have patients, sometimes patients are cured at the beginning, but most patients, or many patients, may have to have 1 or 2 rounds of radioactive iodine. The bad news is that 25 to 50% of people with metastatic disease, so you'll cure some of them, but 25 to 50% of the people with metastatic disease will ultimately lose the ability to take up radioactive iodine. And this is known molecularly to be due to the downregulation of the sodium iodine symporter, as well as other proteins that are used to trap the iodine inside the cell. So this cancer cells basically forget how to respond to this agent, and now these patients, at least as of 5 years ago or so, had no hope of what to do. So we did know that chemotherapy had been approved in 1974. Doxorubicin was approved back then. However, due to very low response rates, high toxicity, and the development of CAT scans that showed that people were progressing way before we thought they were, this is no longer the standard of care. So patients would be given doxorubicin as sort of when they're in the very end stages of their disease and not before. And that's because many of these patients, even with metastatic disease, have a fairly healthy life. And they have it's amazing the amount of tumor burden they can actually live with. And if it was a different type of tumor, they might be very sick. But it turns out these are relatively healthy people. And for that reason, doxorubicin is not routinely used unless sort of at the end stage of the game. And also, my endocrine colleagues didn't send any patients to oncologists for a very long time. So what have we learned about thyroid cancer in the last 10 years? Well, it's clear that thyroid cancer is, if nothing else, a cancer of aberrant cell signaling. And so what we know is that we have BRAF mutations in a large number of papillary thyroid cancer cells, but overall, with other mutations that have now been detected, there's a very large proportion of mutations that have been detected both in the MAP kinase and the PI3 kinase pathway, and a couple of other pathways as well. So if we looked at all the cell signaling involved, probably over 70 or 75% of thyroid cancers are actually attributed to alterations in signaling, cell signaling. And of course, this couldn't have happened at a better time because we now have kinase inhibitors. The other thing we know about thyroid cancer, and this slide always reminds me to tell people, is that thyroid cancer is actually a very vascular tumor. So in a way, like renal cell, these are very bloody tumors, and because of that, there was always an interest in anti-angiogenic activities from different chemotherapies, and had actually started to be tried even before we were using kinase inhibitors. So we can look at both what the activities are in the endothelial cell and the tumor cell, and conveniently for us, the downstream pathways tend to be the same. At least they overlap significantly with heavy dependence on both the MAP kinase and the PI3 kinase pathway. And when I first started out, we had basically two kinases to choose from, sorafenib and sunitinib. And at this point, we actually have many different ones that have been tried, and actually quite a bit of phase 2 data on most of these agents. So what can we say? So the first kinase that we were studying was from 2006 to 2011, where we studied 55 patients at Penn who had metastatic iodine refractory tumor. Now, these people had progressed. There wasn't any rigorous criteria as to how quickly they had progressed, but they definitely had progressed, usually within a year of starting. They were given sorafenib, 400 milligrams twice a day, and they were studied for both their response as well as progression-free and overall survival. So this was actually published early, partly because we reached our primary endpoint when we did our futility analysis at 30 patients, because the progression-free survival was really quite significant, and was in the range of 20-25%. So because of this, we were able to get the interest of the folks at Bayer. And the phase 3 was immediately designed. Well, not immediately. It took maybe about a year and a half of convincing them that thyroid mattered. But they eventually did design this, and they called it the decision trial. And the decision trial basically clarified a little bit the eligibility criteria for us. And we really had to pool a lot of information from endocrinologists who treat this regularly, as well as oncologists, to really make sure we were treating a group of patients who needed to be treated. Because many people with this disease, it's a very, very slow-growing tumor, and you don't want to be giving people toxicity if they're going to live perfectly well without it for a long period of time. So the eligibility was made that they had to have RECIST criteria progression within a year, and we made it 14 months to give people a little leeway in case they had a dentist appointment and couldn't get it in within 12 months. And then in addition, they had to be RAI refractory, documented that they were not taking up iodine, or that they had progressed after the last time they had been treated. And of course, it was in this case given as first-line therapy. It was randomized between placebo and the study arm. It was 1-to-1. And then at progression, they were actually, because we knew that many patients would get sorafenib off-label based on the data from the phase 2 study, we did allow crossover so that we would be able to still continue to study the patients after they had progressed. And so they did this, and I will say happily that in January, the press release came out that this is a positive trial, and I hope to be presenting this at ASCO this spring. So what do we have in addition, and I alluded to this earlier, that sorafenib at this point is by no means the only game in town. There are many VEGF receptor inhibitors and other inhibitors that have been tried now in phase 2 studies. And if you look at all the ones that are positive, it's not surprising if you see what they have in common. Most of them have they are anti-angiogenic. But in addition to that, they have different other activities. And down the line, maybe when we study larger populations, we may find that there's slight differences in activity, possibly due to these other targets. But in general, the thing to know is that it's clear that anti-VEGF receptor inhibitors do seem to work. And I will say also the one at the bottom, lenvatinib, is now also been studied in a phase 3 in the SELECT trial. The SELECT trial ended its accrual in the fall, and it's probably about a year behind what's going on with the sorafenib story. And so we actually have 2 phase 3 studies that have been going forward in this indication. So in summary, we know that differentiated thyroid cancer is a vascular tumor. It has increased activity of the MAP kinase as well as the PI3 kinase AKT pathways. iodine refractory patients, I took out the slide for this in order to make it a little bit shorter, but what I should have pointed out, the reason we care about them progressing and that they've lost iodine activity is that's when their survival falls off. And we know that they have an average survival of only 3 years. So where everybody says, oh, thyroid cancer is a wonderful tumor, well, it really isn't once you stop taking up iodine and your tumor is progressing. So because of this, we really did have an unmet need, people who needed to be treated. And so because of the phase 2 trials with sorafenib, additional studies, both with sorafenib, lenvatinib, and many other phase 2 studies have gone forward. And additional MAP kinase inhibitors are underway to study not just MAP kinase and not just VEGF receptor inhibition, but also mTOR MEK inhibitors directly, as well as BRAF inhibitors, one of which we have going on at our institution, which is the use of vemurafenib, which was the melanoma drug, now using that against the BRAF V600E thyroid cancer patients. And so that also is moving forward, and hopefully in the coming year we'll have the data for that. So the one thing I will say is that what do you do when you have patients who've done very well on sorafenib for a while, but of course, if they only do well for about a year or 2 years, at some point they may develop ability to grow in spite of it. And what we need are additional treatment options in the second line. And so what we had done at our site is that we had taken out a lymph node from a patient who was progressing and noticed that the PI3 kinase AKT pathway was still upregulated. And so we wanted to try to study the combination. And because of that, we actually have designed a phase 2 where we take all of our patients who progressed on sorafenib, but instead of actually, because of heterogeneity in the responses, sometimes much of their disease would be still responding and only part of it was progressing, we were hesitant to actually stop the sorafenib. So the way this study is designed, we actually continue the sorafenib, and now we add in everolimus. And we were able to do this successfully. The toxicity was actually more manageable than we ever expected it to be. And we're probably about, I think we just put our 24th patient on yesterday. So this is a study that's going forward. There are additional ones, as I alluded to, with the V600E mutation, both looking at first-line setting as well as patients who are treatment naive. This stopped enrolling in October, or I think maybe the last one was in January. And so this is also maturing as well, and we hope to get the data. I have to put this up because this slide changes almost every month. And it really talks about how we're rapidly evolving new treatments. But I think at this point, sorafenib is still the front runner, although lenvatinib is close behind. We also have second-line therapies, and now even third-line, if you think of all the different things that we found out in phase 2, including pazopanib and other agents that, at least if they're FDA approved for another indication, we're able to get them. So we routinely treat people in the third line with other drugs such as pazopanib or some of these other agents. We have nothing else to give them, and they need something. So another interesting thing I'll just say about differentiated before I move on to medullary is there was some very interesting data last year at ASCO about the use of MEK inhibitors based on some really beautiful work by Jim Fagan at Memorial Sloan Kettering to see whether or not you could actually redifferentiate the tumor cells, which it looks like happens after you treat thyroid cells with a MEK inhibitor, and then see what happens with the iodine uptake. And this was actually a proof of concept pilot that showed that if you take a patient who does not take up iodine very well, and you give them 5 weeks or 6 weeks of solumetinib, which is a MEK inhibitor, and then you study them again, a subset of those people will have increased radioactive iodine, and 2/3 of those patients will have a good enough uptake of iodine to actually require treatment. And so actually this has turned into phase 3, but instead of doing it in this setting, they've moved it forward as an adjuvant, taking patients who are high risk of recurrence and are now actually studying it when they get their first radioactive iodine to see whether or not the solumetinib might decrease the number of people who have recurrence at 1 year, because that still is a very high number with people with positive margins and things, and this is going to be opening in the next couple of months at our site as well. So second-line agents, because of heterogeneity, putting a person on multikinase inhibitor, either sequentially or in combination, they may derive benefit. And also that we're studying new agents to target the tumor cells. So stay tuned. So medullary thyroid cancer. It's funny, medullary thyroid cancer is much more rare than differentiated thyroid cancer, and yet we've had much more notoriety and success with FDA approvals in medullary, and that has a little bit to do with its molecular biology. Again, a tumor that is very dependent on intracellular signaling, and of course what you see here on the left-hand side is the most important molecular event of all in medullary thyroid cancer, which is of course mutations in the RET gene, which leads to the development of both familial forms forms of medullary thyroid cancer, as well as sporadic. So up to 75% of patients with medullary thyroid cancer will have it due to or have it associated with a RET mutation, regardless of whether it's either sporadic or whether it's hereditary. So again, the downstream pathways are similar, and you'll see you'll see that a lot of the agents that have been tried in differentiated have also been tried in medullary. And I didn't really go into all of them. I talked about the 3 of the first ones that were published, although I will say there's now data with pazopanib. There is some data from mixed trials with sunitinib and a couple of other agents. But let me just point out that vendetinib and cabozantinib are the ones that have gone forward with phase 3. Sorafenib has not. There's been some phase 2 data to show activity, but not phase 3. And so both vendetinib and cabozantinib have gone forward. Now, I want to point out a very important thing. Medullary thyroid cancer is not that different than differentiated thyroid cancer in that it can be slow growing. So some patients grow very slowly and some patients grow more quickly. And these studies were actually started before people really got together and said, who should we really be treating? What are the criteria? So the first study, which was the Zeta study, which was done for vendetinib, the phase 3 that was positive and led to its approval in April of 2011, interestingly did not ask for progression. So they treated both people who were progressing and both people who aren't. And so this is actually the progression-free survival curve from the Zeta study. And interestingly, what you'll see is that the progression-free survival for the placebo was 16.4 months. Now, that's an awful long time to be doing well without any toxicity. And so what's interesting about it is maybe only half of the patients are people that at this point we would actually recommend treating. So you have to keep that in mind, of course, then when you actually look at the people who are still, the PFS actually was not reached. And a lot of people reading this, I'm sure, may not actually appreciate that important point, and expecting people to be out over 22 months on these agents with the people that we'd recommend treating is just not what you're going to be seeing in the clinic. However, when the cabozantinib study was put together, that was a consideration that was made, and because of that, they required that people, again, had progression-free survival, progression based on RECIST, and that actually was confirmed by an independent review prior to eligibility. So this is a group of people that really are the ones we want to treat, the ones that are clearly progressing over this 12-month period. And now you'll see a very different placebo progression-free survival of only 4 months. And medullary really can be a very aggressive disease, and I think this group of patients is really more reflective of the people that I'm treating in my clinic. The people who are not progressing, I have them on surveillance, and they're not actually starting treatment. But now you see, again, a beautiful positive positive benefit to cabozantinib going from 4 months to 11.2 months. And based on this, cabozantinib was actually approved in November of last year. So now there's actually 2 first-line treatments for these two agents. The one thing I will point out is that with vendetinib and cabozantinib, they're very, very different drugs to give. And vendetinib seems to have more problems and issues with QT prolongation. And so actually, in order to even give this drug, you have to do a REMS program. And there is quite a rigorous set of EKGs you have to be following at all times and dose reduce if the QT prolongation gets too long because of the risk, of course, of arrhythmias. Cabozantinib, on the other hand, has a black box warning about people who might be at high risk of fistulas and perforations, either inflammation in the lower GI tract because they have a lot of diverticuli or Crohn's or ulcerative colitis. And they also saw some people who had fistulas up in the area of the neck. Now, that's not too unusual because people who have disease that might be wedged right between the esophagus and the trachea, that often cannot be removed, and it's not clear what happens. It's clear that they're at risk of fistulas and other problems when that starts responding to these agents. So they're very different. You have to kind of think of the risks of both. In reality, because we're only talking about responses averaging 11 months, all of my patients are probably going to end up seeing both. So I probably will sequence them based on which one I like to do first with each one. So a summary for all the agents with medullary thyroid cancer is the phase 2 data shows several multi-kinase inhibitors are clinically active in patients with differentiated and medullary thyroid cancer. Vendetinib, I forgot to update this, I think. Because I have Cabo had not been FDA approved, but now both vendetinib and cabozantinib have been FDA approved, and then additional agents now again are needed because patients, they're very healthy again, and after they've now failed 1 or 2, now 2 agents, they still are in need of what I would say third-line agents. And in that case, I will say that the phase 2 data for sorafenib and even pazopanib and some of these other phase 2 are good choices in that setting. So where do we go from here for targeted therapy? We need completion of all the large randomized trials that are out there, many of which that were already planned are complete. A few new ones are actually starting to be planned and started up now. So we're about to get past what I would say is sort of like the first wave of agents. But then we need more information on sort of who are the patients that are responding, why are they responding, and what do we do when they stop responding. So that's really what I've sort of listed on the rest of this slide. Further subgroup analysis, of course, will come out of better genetics and things which we are looking for. We do large genetic screens for these patients for other targeted abnormalities. And I was trying to convince the Bayer people to do a registration trial of sorafenib in medullary thyroid cancer because it does have activity. But again, for them, it's a business decision, and they have not been interested thus far. So these are different agents that are currently in our thyroid cancer program, a large list, and it's sort of nice because then patients come to us. We have a large menu for our buffet of different things that they can get when they're getting treated. And it really has been nice, I think, for the patients in our center just because they don't have to jump from one place to another, and that gives them a little bit of continuity. And we can also sequence them. And then we have additional trials that are going to be opening up soon, of quite a large number, which is nice because, again, this is how I get access to these agents to be able to help my patients as best as possible. I could not do this work without a large group of people who are thyroid experts in my institution that have helped me along the way. And I think that, I'm always happy to take questions.